Good afternoon, everyone. It's Michael Michal here. We'll start with first case. This was a 30-year-old lady with a tumor on her forearm. So a skin lesion, relatively common tumor, completely benign. It's often multinodular. In this case, it's uni or binodular perhaps. Typically myxoid like this, with prominent these thin or curvilinear, slightly curvilinear vessels. And when you go on higher power, the tumor cells are very bland, without atypia, without mitosis, typically spindled or stellate in appearance. Occasionally you can see dispersed neutrophils. And this is superficial angiomyxoma, sometimes called cutaneous myxoma. So when these tumors are multiple, they can be associated with Carney complex, but most cases are solitary, not associated with any syndromic, with any syndromes. So superficial angiomyxoma. Immunohistochemistry is not very helpful for the diagnosis. Some cases may have loss of percar1A staining, but most people don't have this IHC in their lab. Okay, another case was a 70-year-old patient, lady, with a multifocal peritoneal nodules, which were thought to be metastatic lesions, and she was supposed to have some GYN tumor, most likely ovarian tumor. So this was and also she had a large liver lesion, cystic liver lesion of like 12 or 15 centimeters in dimension, so big liver lesion at the same time. So this is a punch biopsy from the peritoneal lesion, which look so suspicious for metastatic disease, potentially some gynecological carcinoma. But as you can see here, this is rather composed of, again, spindled cells, relatively bland, without mitosis, and with quite prominent eosinophilic cytoplasm. Sometimes it's arranged in these short fascicles, somewhat intersecting short fascicles. And when these fascicles are, or the cells, tumor cells are cut longitudinally, you can see the kind of like a cigar-shaped nuclei as here in the center. And indeed, by immunohistochemistry, there was diffuse Jasmine and H-caldesmon expression. This is H-caldesmon, so this looks like it looks like a uterine leiomyoma basically, but if it's on the peritoneum, it's extrauterine leiomyoma. Yeah, so classic smooth muscle tumor with the appearance of uterine leiomyoma. So the next lesion, we had also biopsy from the liver lesion. Very small, largely necrotic fragments of something that looked very different. So this is, at first sight, this is high-grade malignant lesion, composed of spindled, sometimes epithelioid cells, high-grade nuclear atypia, and dispersed, you can see these kind of chondroid areas. There will be better ones to show. Here you can see highly atypical cells, a lot of mitosis, including some atypical ones. So this is the 12 centimeter or 15 centimeter, I don't recall exactly, liver lesion. Here again, here's, I would say, already clear-cut chondroid differentiation. So we have some high-grade malignancy with chondroid differentiation. And as I mentioned, there was a suspicion for Gynecological tumor, most likely ovarian. Here's another slide. I think there were, okay, so there were some more easily distinguishable chondroid differentiation. So we have some suspicion for gynecological tumor. So we did besides markers for melanoma like S100, SOX10, we also did PAX8 cytokeratins. This here are cytokeratins, so diffusely positive. So originally this was most likely epithelioid proliferation. PAX8 was also positive in the spindled and epithelioid cells. Another very good marker of Müllerian origin is SOX17. Some authors claim that this is better marker than PAX8. I usually use both if I have high suspicion. So this is a nuclear marker again, clearly positive. And so this looks like a epithelial malignancy of gynecological origin with chondroid differentiation. So that's what we said in the diagnosis, and that at first place differential diagnosis includes malignant mixed Müllerian tumor, basically carcinosarcoma with chondroid differentiation. And obviously at least some of the peritoneal lesions are not metastatic foci. Those are either it was solitary peritoneal leiomyoma, extrauterine type, or perhaps the patient may have disseminated peritoneal leiomyomatosis. Okay, next case was a 25-year-old male with a tumor on his back. So this was, sorry, it's not a good view, scanning magnification, so it's going higher power. So some at the periphery fibroadipose tissue, and in the center you have a quite well circumscribed but non-encapsulated tumor, again composed mostly of fibrous tissue and some very hypocellular proliferation of bland spindled cells. There was no mitotic activity, no atypia, and I'm looking just for some most illustrative areas. Okay, here maybe. For this diagnosis, I think it's desmoplastic fibroblastoma. I love the clue my father taught me. I don't know if he came up with it himself or he read about it, but he said that this tumor resembles the spermiogram of infertile male, and I think it's a very helpful clue. Obviously I had to Google how it looks like. You can try it, and it really looks. The tumor cells look similar in shape and with regard to kind of like a cellularity and the amount of tumor cells. So desmoplastic fibroblastoma, this is completely benign tumor. It's useful for clinicians if you mention that it's a completely benign tumor, because the name desmoplastic and fibroblastoma kind of involves malignancy, but it's completely benign. It usually does not recur at all. So next case was a 23-year-old male with a tumor, again, on his back. It's quite common, but for the residents in the audience, also skin excision with quite deep margins. And at first sight, from low power, the tumor actually is hard to see, but there is some collagenous tissue, some chronic inflammatory cells. The epidermis is unremarkable completely, but if you go on higher power, you may notice between the collagenous bundles is a tumor with clear cytoplasm, again very bland nuclear features, especially in some areas when more tumor cells are present next to each other. It's better appreciable. So if you know the diagnosis, it's easy. You go straight for SOX10, S100, and perhaps inhibin to confirm the diagnosis. If you don't know, you can start with some default immunohistochemical panel, which also contains SOX10 and S100. And so this tumor is diffusely SOX10 and S100 positive. It's a granular cell tumor of soft tissues. And useful marker is inhibin. These tumors are typically inhibin positive. Inhibin in our lab is quite weakly positive usually, so the expression is not spectacular, but you can see some cytoplasmic expression of inhibin as well. I think even SF1 is positive, if I'm not mistaken, in these tumors. You can use SF1 as well. So granular cell tumor of soft tissues. Next case was a young guy in his 20s, tumor on his finger, sorry. And we have these fragments, which, however, kind of still show the multinodularity of this tumor. This is a new entity, new variant of a tumor that has been called for many decades as a chondroma of soft tissues. But some 5 years ago, French authors found a recurrent THBS1 gene fusions in these completely benign tumors. And now this tumor is separated, or probably will be separated, either as a subtype of chondroma of soft tissues or as a different entity called most likely acrofibrocondromyxoid tumor. And so how do you recognize this tumor? It's, again, multinodular lesion, typically on the fingers or toes. It can be in the dermis. Most commonly, it's in the subcutis. Occasionally, it can be also in the bone. And the lobules are composed of this kind of like a chondroid matrix. Occasionally, you can see even a mature hyaline cartilage areas, but not in the minority of cases. Most cases don't have mature hyaline cartilage, and the chondroid, immature chondroid matrix contains these again bland, spindle to somewhat reniform cells with variable cellularity, but predominantly it's a quite hypocellular tumor. Another useful feature is that it's hard to see here due to the fragmentation, but between the lobules are fibrous septae, which contain often prominent vessels. I don't see any good, maybe here, any good example here. Actually, so far all cases contain the same THBS1 fusion. Okay, here's a follow-up paper. The first paper by the French group was in 2019. And 2 months ago, a group of around Karina Danner and John Kissinger published this larger follow-up series of 37 cases, basically confirming the findings. Here is the fusion. It's definitely not necessary to confirm the fusion because the morphology is very characteristic. It's usually very similar from one case to another. You can see the chondroid matrix here, usually low cellularity, occasionally mature hyaline cartilage. Otherwise, if you would like some help from immunohistochemistry, you can stain for ERK, which will be typically positive, because those cells are really probably chondrocytes, some immature chondrocytes. Also, CD34 is often positive. Again, it's completely benign tumor, and complete excision is enough for this. Okay, here are the vessels, prominent vessels between the septae that separate the nodules. Okay, so acrofibrocondromyxoid tumor. Kind of awkward name, but if you remember it, you will know how the tumor looks like. And last case for me was a 69-year-old female with a tumor which was arising in around her sacral vertebra from the spinal cord, from radix of the peripheral nerve. And here is the morphology. So it was a kind of like a cystic tumor, very hemorrhagic, with dispersed calcifications. And from this low power, it almost looks like some reparative changes, some reactive changes after some hemorrhage. But actually, the pigment is not hemosiderin. It's definitely melanin. And if you go on higher power, you will eventually see that there is actually quite a lot of tumor cells, but they are kind of buried in the melanin pigment. You can see these very large epithelioid cells with prominent nucleoli here in the center, for example. There was quite low mitotic activity. And so if you see this combination of large epithelioid cells, heavily pigmented neoplasm, and also, especially if you have these calcifications, which in some foci are clearly, they have a pseudomatous appearance, especially if you see it in this location around the spinal cord. This is highly suspicious for a tumor that was formerly called pseudomatous schwannoma. It was originally thought it's a variant of schwannoma, but it's not. I'll say more about it right away, but let's look what can help us. So this is S100 protein, which is diffusely positive in the tumor cells. Even better for me, at least, is SOX10, which is a nuclear marker, so you can nicely separate the pigment from the expression in the nuclei. So diffusely positive. You can also stain for melanocytic markers such as HNB45 or melan A, which will be typically diffusely positive as well. This is HNB45. And virtually a diagnostic marker is PRCAR1A immunohistochemistry. Again, this tumor is in some patients associated with Carney syndrome or Carney complex. I never know the Carney complex. And PRCAR1A staining is a cytoplasmic staining. And there is typically loss in the tumor cells and retained expression in non-tumor cells. So here in the center, for example, with the heavily pigmented cytoplasm, you can see clearly loss of expression in the cytoplasm, and the same in the vast majority, perhaps all tumor cells. The cells with expression will most likely not be tumor cells. If you find some, lymphoid tissue, there is clear expression. Okay, and as I mentioned, it was originally called pseudomatous schwannoma, since it was thought to be a variant of schwannoma, and it was believed to be very low-grade tumor, which is usually benign. But subsequent series with longer follow-up showed that this tumor is a high-grade malignancy. Metastases were found in almost half of cases in this biggest series by Andrew Folk. There is currently no accepted histological feature that would predict malignancy. The only thing that seems to have some relation to prognosis is mitotic rate. If it's more than 2 per 10, somewhat more likely, but it doesn't work 100%. In many cases have PRCAR1A loss of expression. I think the percentage here is somewhat lower. I think even the authors today think that they included some cellular blue nevi in the series, so it's kind of skewed to a lower percentage. In my experience, most cases have loss of expression, and you can see that basically almost all cases were around the spinal cord here. and morphology, at least in these areas, is identical to what we see here. The pseudomatous calcifications are usually present, but not always. But if they are there, it's extremely helpful, because obviously the biggest problem here is to differentiate it from malignant melanoma. Regarding the terminology, the term melanotic schwannoma has been abandoned, and now the WHO calls these tumors malignant melanotic nerve sheath tumor. So not even this name was used, but now it's malignant melanotic nerve sheath tumor, and it's considered high-grade malignancy. Last picture I want to show here is a gene expression profiling. One of these colors, okay, this green one is schwannoma, blue is melanotic schwannoma, and red is melanoma. So you can see the gene expression profiles of each of these entities is completely different. So this is another support. These tumors are different entities. Okay, that's all from me.
Yeah, my first case, the old one. The first case is skin lesion. And at the first slide, what you see is great proliferation of sebaceous glands. So that you would say that it might be a case of so-called trichodiscoma, but if you look into the stroma, you find here this proliferation, which has morphology indistinguishable from spindle cell lipoma. I saw even some lipoblast in it. And very importantly, this proliferation, this mesenchymal proliferation has you can see in the middle, the mesenchymal proliferation has a loss of retinoblastoma protein, the positivity abscess. Yeah? It just confirms that what is in the stroma is really spindle cell lipoma, and probably that retinoblastoma protein positive sebaceous glands are just reactive changes. And we published that very recently, 2019. Posledně se poslal. Ne, to ne, to před, teď jsem to poslal mailem. Ne, teď jsem ji poslal jedno mailem. We published it in this coincidation of spindle cell proliferation in the stroma and sebaceous hyperplasia. And we think that the primary event is not sebaceous proliferation, but the primary event is the stromal proliferation, and all the rest is just hyperplasia. Yeah. Do you have it? Yeah, it is that. Yeah. You see spindle cell predominant trichodiscoma or spindle cell lipoma with adnexal induction. We think the second part of that is truth. Ještě mi zvětšit to jde, práce?
Jo, ještě je plus. Je prostřed zhruba.
Yeah. You see here as well, here is the proliferation of spindle cells, and around sebaceous proliferation sometimes having the typical structure of banana shapes. Here you can see spindle cell lipoma. Here you can see spindle cell lipoma, including many lipoblasts, and we in another paper wrote that spindle cell lipoma has nearly in half of the cases as lipoblast, and all the rest of it is just hyperplasia around it. Yeah? You will get the reprint to read it. Another important paper and case I saw in our data files, it's new entity of salivary glands published in a March issue of AJS American Surgical Pathology. You see here is small oral salivary gland with such mucinous proliferation that looks indistinguishable from, for example, metastatic mucinous carcinoma of stomach. And you should not forget about this new entity, which is primary in salivary gland. And typical for these cases is that practically in all cases, these lesions are BRAF mutated, the typical canonic V600E mutation. It was published in March in American Journal of Surgical Pathology. Again, you will get this paper. You should be well known that primary mucinous adenocarcinoma, it can be in salivary glands with BRAF mutation. This paper describes another entity, this papillary proliferation, and this papillary arranged tumor is not BRAF mutated, it's got typical ACT17, I guess, yeah? ACT1 mutation, yeah, it's not this case. Because it's a very old case, we could not prove BRAF mutation by genetics, but we did immunohistochemical staining for BRAF mutation, and we found very nice intranuclear positivity in this tumor. Yeah, you can see it. Yeah. So the BRAF mutated primary colloid carcinoma of salivary gland. I think that BRAF is not mutated in any other colloid carcinomas elsewhere in the body, so that we can nicely say that it's the primary lesion of salivary gland. Another case is tumor of newborn patient in nasopharynx. We are now finishing a paper about this very enigmatic type of lesions. The tumor has typically two components. First of them is squamous cell differentiation, usually on the surface. It's nearly always congenital or in small babies of several months of age. Yeah. Here is the syringoid lesions layered by squamous cells. And another component is spindle cell proliferation that looks like schwannoma or pleomorphic adenoma. The tumor was described by Rossai and Denner under the name salivary Anlage tumor. There is not known any driving genetic mutation or fusion because probably the panels of nowadays are not strong enough. But what we found is that all of these cases are immunohistochemically retinoblastoma 1 protein deleted. Yeah? It is a hallmark of it. We didn't find genetic mutation of retinoblastoma protein, but it may be caused by some epigenetic mechanism. Another case is case of older patient. I don't remember male or female, but it's not important. of another nasal cavity. It's case from Singapore, and we just published 31 cases of this coincidence. What we can, what you can see here is our Ceremosinus hamartomas. For example, here you can. And these Ceremosinus hamartomas are changing into atypical forms, like you can see here. And they gradually change into adenocystic carcinoma, like you can see here, including perineal invasion. And we think that a big part of tumors in this location is having origin in Ceremosinus hamartomas, which differentiate into atypical forms and into malignant forms. We published very recently a paper about adenosquamous carcinoma arising in these structures as well, so that we think that it is so far undescribed pathway of creation of adenocarcinomas in a nasal cavity. Just until now, it was recognized that nasal tumors had two types of adenocarcinomas. One of them was that arising from intestinal metaplasia, intestinal adenocarcinoma. The second was called non-intestinal adenocarcinoma, but these are heterogeneous. There are many types of adenocarcinomas. And big part of them arises this pathway, that means from Ceremosinus hamartoma into atypical Ceremosinus hamartoma into adenocarcinoma. And main tumor that appears like that is adenocystic carcinoma. So that we are submitting 31 cases of adenocystic carcinoma arising in Ceremosinus hamartoma. When it appears, we will send you reprint. Okay, I will give my word to someone else, not the speaker.
Hello everyone who is listening, here is Rita Michalova. My first case is a testicular case, and it is a man aged 1987 born, and here we have the tumor of the testis, which is well circumscribed tumor. And here in this part, we have area of tubules, which is reminiscent of sertoli cell tumor, NOS. If we are moving here to this part, we have area which is similar rather to tumors as macrocystic stromal tumors of the ovary. And if we are moving to another part, there are more solid areas, like here. If we use immunohistochemistry, the tumor is positive. This is beta-catenin, and we can see that the tumor is strongly aberrantly positive with beta-catenin in all of the morphological patterns. There is nuclear and cytoplasmatic positivity in all of the cells throughout the tumor. SF1, which is another, which is a best marker for sex cord stromal tumors, and clearly distinguish its positivity distinguish the sex cord stromal tumors with another entities occurring in the testis. Here we have also strong diffuse nuclear positivity in the tumor. But another markers which are often positive in other types of sex-cord stroma tumors of ovary and testis are calretinin and inhibin, and in this case, these markers are typically negative. So this is calretinin. It is negative in the tumor. And then inhibin, which is similarly negative. Also, as an initial marker which was performed was OCT3, 4, and SAL4, thus markers of germ cell tumors in general, and OCT4, 3, 4 is marker of seminoma and embryonal carcinoma in the testicular tumors. Both were negative, so this was sex-cord stroma tumor with positivity with SF1 and negativity with calretinin and inhibin. Another positive markers were cyclin D1 and CD10, both were diffusely positive, and there was focal positivity with NSA and synaptophysin. This immunoprofile is typical for more tumors. In the testes, it is typical for cell cell tumors. In ovary, it is the typical immunoprofile for microcystic stroma tumor of the ovary. Here is the area similar to this type of tumor. And then another tumor with similar immunophenotype is solid pseudopapillary tumor of the pancreas, which here in this part of the tumor we have area with similar cytology to this pancreatic tumor. All of these entities are mutated in beta-catenin gene in exon 3, and we think that these tumors are belonging into the same category of beta-catenin mutated tumors. And now we are the methylation analysis comparing these tumors, so sertoli cell tumors, solid pseudopapillary tumors of the pancreas, and also microcystic stroma tumors of the ovary. We are doing the methylation profiling of them to prove if this is a true statement or not, but based on the overlapping morphology, based on the presence of these morphological areas which can be seen in these three entities together with immunophenotype, we think that this might be successful, this methylation analysis, but we will see in months or so. Another tumor, it is also from the testes, and here we have another sex-cord lesion. In this case, it was not genuine tumor. In this case, we had we have clinical information which were enough to properly diagnose this tumor. It was a young man, 1988, and the most important clinical information was the presence of adrenogenital syndrome in this man. And for men with adrenogenital syndrome, there are typical the lesions occurring in the testes are so-called tumors of adrenogenital syndrome. These lesions are not genuine tumors, these are tumor-like lesions, and these lesions are very similar to Leydig cell tumors and are occurring only in men who are improperly treated or who are not yet diagnosed with adrenogenital syndrome. Otherwise, the clinician don't undergo biopsy for treated and controlled patients. But if we have patient with tumor of adrenogenital syndrome, we can see something, as I said, similar to Leydig cell tumor, but there are some aspects which are different. The first aspect is the presence of these fibrous septa, which are creating the tumor of lobular appearance, which is not very typical for Leydig cell tumor. Yeah, Leydig cell tumors are usually the solid masses without the septa. Another here is nice septum. Another typical feature of tumors of adrenogenital syndrome is the presence of lymphocytic infiltration, like here. Another thing is if you have in the eye these type of tumors, it is the the presence of more variable tumor cells or lesional cells in case of tumor of adrenogenital syndrome. Another feature is the entrapment of non-neoplastic germ cell tubules, which is in here present. So in this case, we could easily make the diagnosis of a tumor of adrenogenital syndrome, or so-called tumor of adrenogenital syndrome. It is important to distinguish it from lytic cell tumors in case the clinician wouldn't provide you clinical information, which is not very rare. It is important to know, to be aware about these morphological differences between them, because after you made the diagnosis of so-called tumor of adrenogenital syndrome, the patient is not treated surgically, which you would be treated surgically in case of genuine lytic cell tumor. This patient will undergo conservative treatment of his syndrome, and the lesions are supposed to disappear afterwards. Another case is the biopsy from uterus, and the patient is old patient, born 1949, and the clinical diagnosis was leiomyoma of the uterus. And here's what we see in the specimen, which was supposed to be leiomyoma. We can clearly see that this is not leiomyoma, this is something different. Here we have epithelioid cells with very voluminous mucinous cytoplasm. So there are signaturing cells dispersed in the uterine wall. Here was another maybe better example of another specimen from the uterus. Well, it is not the best. Yeah, here. Here the lesion is infiltrating in between the preformed normal non-neoplastic endometrial glands, which you can see here. And there were four biopsies from endocervix, from both sides of the uterus, and then from one more from endocervix, and all of these looked like this. So as for immunoprofile, these lesions were positive for CDX. This lesion was positive for CDX2, which we can see here. So the first impression was that this is a metastasis from signaturing or poorly cohesive carcinoma of the stomach. But there was this is CK7. CK7 was negative. So it is weird for gastric signaturing carcinoma to be CK7 negative. Another used marker was SADB2, which was diffusely positive, similarly to CDX2. There was diffuse positivity of cytokeratin, A13, and this is CK20. So the immunoprofile, it is a signaturing cell tumor with CK20, CDX2, and SADB2 positivity. So this is probably either the metastatic involvement or the direct spread of so-called signaturing or poorly cohesive carcinomas, which can also occur in the colon, which is rare, but it does exist, and the immunoprofile fits. And these tumors, according to what is described in the literature, usually are very aggressive and metastasize to unusual locations, as opposed to conventional colorectal carcinoma. So this case was probably the secondary involvement of uterus and uterine cervix of this type of carcinoma. So signaturing cell carcinoma of the colon. Another biopsy was, this was a patient born 1966, and there were two locations of the biopsy, two different biopsies. The first one was a biopsy of the liver, And here we can see the liver parenchyma, which there is fibrosis, almost cirrhosis, and there is some neoplastic lesion. And the patient had also a biopsy from cecum, and in the colon there was adenocarcinoma. So the first impression was the logical process would be this is a primary colonic adenocarcinoma metastasizing to the liver, which is a very frequent situation, and it is not. It was proved many times that if you have cirrhotic liver, it is not that the metastatic tumor also exists in cirrhotic liver. So there was a presume for many decades, many years that once you have cirrhotic liver, the only chance to have a tumor is a primary tumor, because of portal hypertension there is no option for the tumors to metastasize in because of the pressure gradient, but it is not true anymore. So colonic. In this case, the first impression was this is a colonic primary carcinoma metastasizing to the liver. But the problem was that if I had only the colonic biopsy, I would maybe don't do many immunostains. But for the liver lesion, I did CDX2 and SADB2 to confirm that this is coming from the colon. And it is not coming from the colon because it was negative. This is CDX2, completely negative in tumor cells, as well as SADB2, which is here, also completely negative. And after a couple of other immunos, neuroendocrine tumors, and so the positive immunostains were CK7 and CK19. So this is probably the primary cholangiocarcinoma metastasizing to the colon, which is the weird and vice versa situation that we are used to. But these were the only markers positive. And as for cholangiocarcinoma, primary cholangiocarcinoma, it does not have any specific or very characteristic immunomarkers. It's always diagnosis of exclusion, so it will have to be correlate clinically, but this is probably going from primary cholangiocarcinoma secondary into the colon. And my last case is from endometrium. It was 87-year-old woman, and was clinical suspicion of carcinoma, and we can see that there are fragments of atypical endometrial glands. So if there was no such prominent inflammatory infiltration, it would be the straightforward diagnosis that this is at least endometrial intraepithelial neoplasia, rather carcinoma. But the problem here is that there is abundant neutrophilic infiltration. So the atypia we can see here in this gland can be either neoplastic or reactive. It would be rather neoplastic, but still it is not so clear because of the inflammation. In these situations, if we are not sure if we are looking at reactive changes in endometrium or neoplastic changes, and neoplastic changes, I mean either intraepithelial neoplasias or invasive lesions. We have some helpful immunomarkers which can distinguish between reactive lesions and neoplastic lesions. There is a panel of immunohistochemical markers which can help you sometime. It is not always helpful, but in this case it was. and the panel contains markers ARID1A, beta-catenin, P10, and MSH MMR proteins. So the proteins corresponding to the genes which are frequently mutated in the endometrial carcinoma. This is ARID1A, and here we have the non-neoplastic lesion compared to now we know it is neoplastic. And in this case, there was also P10 loss, which is this marker, the same area, and we can see that there is a retained expression in non-neoplastic glands and clearly lost expression in neoplastic glands. And also this patient had loss of one marker of MMR proteins, which was MSH6. So this patient has, in addition, probably Lynch syndrome. Other MMR proteins were retained. Sometimes it happens, and very frequently it happens, that this panel of immunomarkers doesn't help you at all because these genes are not mutated in endometrial carcinoma then, but in this case it was helpful, and this was signed out as neoplastic lesion. So that's it for me. Thank you.
Okay, so I have two nice cases, maybe one, and this is the first case. Yes, it was well circumscribed, somehow a little bit maybe encapsulated, but not completely, like cystic tumor, well circumscribed of parotid gland with high magnification. You can clearly appreciate that the tumor was pretty cellular. It was composed of at least two components, with parts being formed by spindle-shaped shaped cells, and then the sort of unusual feature or worrisome feature was the presence of such a microcystic or eosinophilic epithelioid areas, which we may use high magnification to show. Should I change it? Is it better? Or this way? This way. This way. There was irregularities. There were irregularities in nuclei, and that was the reason for consultation of this case. Irregular nuclei with a distinctive large nucleoli. I hope that you can see, and this microcystic growth pattern. So, what was the idea of the pathologist who sent it, that there is a tumor with malignant transformation? However, the finding was not certain. So we did some staining, and it was shown that the tumor was not in all cases like this. So I'll show you a little bit more of it. So in minor parts of the tumor, there was this myxoid transformation of the stroma, and in some other places, which are marked in the second slide, again, these irregular nuclei and large nucleoli. Okay, so the tumor was positive for S100 protein. It was stained also by antibodies for P40 and P63 and SOX10, and mitochondrial antigen. So we tried to make fluorescence in situ hybridization look for alteration in PLAG1 gene, and I've just recent information that there was a alteration break in PLAG1 gene, and we even found unusual fusion of genes of PIK3R1. I do not know that this is a known partner for PLAG1, but what we know is that oncocytic pleomorphic adenomas and myoepitheliomas, which is my diagnosis in this case, do have unusual fusion partners for PLAG1. So this is the final diagnosis is oncocytic myoepithelioma with a strange microcystic solid growth pattern, which we have seen in the minor places already in other cases of oncocytic myoepitheliomas with this unusual fusion of PLAG1 gene with unknown partner. So final diagnosis benign myoepithelioma, unusual oncocytic. So that's my one case, and I think that the next case should be discussed next time, because it's more difficult and more interesting maybe. So, and we've used the time for today.